It is a great honor to be here. I'm sorry that I'm late. I was talking about liability of owners to trespassers or some such things like that. And now I'm going to talk about a topic. And let me just first sort of set the stage for this topic by getting out my lunch. And this is the stage for the topic. Some of you may have heard the rumor that the pharmaceutical industry is one of the larger on the face of the globe, and that rumor turns out to be correct. It's an industry which in current terms has a global sales of around $800 billion. It's likely to go up to $1 trillion in the not too distant future. You're talking about a situation in which the blockbuster drug has always been king. There are about 100 of them, give or take. They average, by definition, over $1 billion in sale. The trend with respect to these blockbusters is in general in slight decline. More of them are going off patent than are coming on to patent, which means that the distribution of power between the pharmaceutical patented companies and the generics is likely to switch in favor of the latter. All of these products compete imperfectly with all these other products in multiple markets and in multiple ways. Now, as somebody who comes out of the sort of the Chicago neoclassical tradition with a wonderful belief in perfect competition, what you predict under perfect competition is that you will have these perfect substitutes going to one another, and that what will happen is that the prices that you observe for the particular products in any particular context will be the sort of the same across the markets. And the first thing, of course, that you do when you look at the pharmaceutical market and you look at the market for grain or for any kind of standard fungible product is you discover that the whole pricing system is much more difficult. And there are both benign and there are some not benign explanations going on with this. And the first thing I would do is to tell you that most markets are now beginning to move in this particular direction, so that, for example, if you look at the hotel market, or if you look at the market for airline tickets, or you look at the market for rental properties, what you typically discover is, even under highly competitive type situations, what you do is you see a continuous revaluation of products almost on an hourly basis. That is, every one of these companies, without exception, now has precise knowledge of local conditions of supply and demand. So if you're a rental company and you've happened to rent one of your 3-bedroom apartments in downtown Houston, the price of the other two now goes up $25 or $50 a month, precisely to reflect those differences. Airline tickets, as all of you know, change prices very rapidly. Same thing with respect to hotel rooms. It's a world in which this kind of information is appropriate. And the question that people always want to ask about themselves is, when you start to see this kind of continuous repricing, which you also see with respect to pharmaceutical industries, although it's for slightly different reasons, should you regard this as a good or a bad thing? And the story that makes this bad, at least in the eyes of some people, is that what you see is that as there are these changes in supply and demand, all of a sudden you get a company which thinks it's in a competitive market that now knows it's got a little opportunity, a little niche for monopoly profits, and when it starts to raise those rents, what it's trying to do is to exploit that short-term niche before it starts to disappear. And some of you would say, we really don't like that kind of mini-monopolization, we ought to discourage it. On the other hand, those of us with sager and wiser and more capacious views, like myself, would say, one of the reasons we get people into competitive markets is the lure that in the second stage of this thing, there'll be a little monopoly that will keep them going, so that the great risk that you do by trying to regulate out all of these kinds of small price variations that you see in the back end of the market is you reduce the size of the folks going into the industry in the first place. And if what you do is have competition coming in at the entry level, it turns out that you'll get more competitors to come in accepting generally lower rates of return precisely because they have these niche options, so that you're probably better off from a global point of view so as to permit these things to be both created and destroyed, so long as there's free entry at the first level, which will increase the supply. And sure enough, if you start to look at the airline industry, the hotel industry, and the rental industry, what you discover about all of them is that the firms on average earn about a competitive rate of return, because all this is priced into the situation, and that it's a more robust and vigorous market because of these ex post variations than it would be otherwise. And the same kind of general argument starts to apply with respect to the pharmaceutical market. That is, what you have to do when you start looking at particular situations at the back end is to ask yourself, what does it tell you about the front end of this market? What does it tell you about the way in which the market operates, not on the individual pricing decision down the road, but way back in research and development and patenting stages when you're trying to figure out how much to invest in what products and to do so what. So that's the first thing. The second thing, of course, is that politics is not always kind to such rational and dispassionate arguments. And in the pharmaceutical business, it turns out that there is a very powerful sort of two-prong attack on this industry. And the first attack comes from the United States, in which we tend to pay, I think most people know this, for the same identical good, more by way of dollar than any other country in the world. In some places it's really an enormous disparity, and all Americans come forward and saying, we believe in the justice of fair prices, we should not have to pay more than anybody else. They're never thinking about the fact that what they really want is people to raise prices elsewhere. What they want to do is to lower them in the United States, and then the question is where? Do you want to lower them to Germany, France, England, Zambia, Mozambique, or whatever? And nobody quite knows what the particular bench line is going to be. And then on the other side, what you do is you have very strong denunciations of a callous and indifferent industry which is only concerned about its bottom line and doesn't understand that these drugs are worth so much to people in impoverished nations who can't possibly afford them. And so you denounce the industry for not having strict, more dramatic forms of price discrimination than it already does. And so essentially what happens is there are now two moral imperatives out there. One is that all prices ought to be equal, and then the second one is that all prices ought to be strictly differential based upon comparative need. And of course it's up to me as a law professor to explain how it is that we can achieve this particular goal. And the only way in which you could do it is to fall on your sword. So this is not particularly appetizing. So rather than start to talk about the great moral virtues of either of these two positions, what I will do is to try to figure out how it is that it comes to pass that you have this particular problem. Now let me just sort of look around this crowd and ask one simple question, because it's going to indicate the way in which my remarks will go. How many of you know about the marginal cost controversy? That's what I figured the answer would be. And so having seen an audience which is steeped in professional economics knowledge, let me give you the illustration as it developed historically, then update it with respect to pharmaceuticals, and then you can see why it is that this is such a difficult market to operate. One of the great puzzles, which was discussed by, amongst others, economists like William Vickery and Ronald Coase, both of whom won Nobel Prizes for their efforts, was the question of how it is that you price a facility to customers when it has the following characteristic. You're building a bridge, it's over the Charles River, right? You remember the Charles Bridge and the Warren Bridge? These are real bridges. And it cost you, let us say, $1 million to build, but once it's up there, it requires zero maintenance so that everybody can go across at zero price. And so the question is, what do you do in order to price this thing? And one of the things you could do is you could use what they call marginal cost pricing. And what that means, in effect, is that you have each person pay the marginal cost that he or she incurs as he crosses the bridge. And so if you look at this, you've got 1 million passengers. It's real easy under the hypothetical that I gave you to figure out the pricing for passengers 2 to 1 million. Well, they all pay zero. It's that first guy who has to pay $1 million. And if you want to then understand what we mean after you as a kind of form of politeness in connection with the marginal cost properties, you can go pay $1 million for that first use, and I'll just pay the zero thereafter. And somebody says, well, that's an extreme example, and that's the old Epstein going on at the mouth again. And I absolutely agree. So let's just make it a little bit more realistic. It cost $1 million to build the bridge, and basically if you look at each subsequent ride, since maintenance is cheap, it costs you $2 to do it. It's the same problem about the differential. Zero just makes the exposition easier, but marginal cost with respect to the operation of bridges is in fact very cheap, and front-end cost is very high. So what do you do with this? And then somebody says, well, you know what, there's a problem about you market guys, is by trying to use marginal cost, you know that the darn thing won't be built. And so what you really ought to do is to solve the problem by having a government subsidy. So the government comes along and it hires Sigler to build this bridge for $1 million, and then people constantly tromp across it at $2 a piece, and we solve the problem. Right? Wrong. Well, first of all, how do we know it's worth building a bridge for $1 million if the only way we do it is through tax subsidies? This may be a bridge over the Charles River, or it may be a bridge to nowhere. It may be one which is going to be built by a great architect or by a complete fool. You have no idea. So essentially what happens is if you want to avoid the marginal cost problem, what you do is you now have a non-market problem as to whether or not you should, through political processes, make a very large lump sum expenditure, and that's not a very easy solution to handle as well. So that if you try to get rid of the marginal cost controversy by having the government solution to it in the healthcare business, what it means is you have to nationalize the industry and have the National Institutes of Health, which doesn't know how to run a clinical trial, try to do this whole thing out of tax revenues. And I got to tell you, it's no point in trying to get rid of a marginal cost controversy by creating a massive public works problem. So the question is, what can you do on the private side? And this is where you start to see how the problem will play itself out. And so you're a drug company now, and you've looked around, and there's nobody who's willing to pay $1.3 billion for the first pill. Everybody's willing to pay maybe $3 or $4 or $2 for the second pill. Essentially what happens is the intellectual structure or the pricing structure of the modern healthcare industry with respect to new pharmaceutical products, not generics, right? They got a relatively flat cost curve. Is identical to that with respect to the bridge. And so what do you do? Well, the answer is, if you can't get the government subsidy or you don't want the government subsidy, what you have to do is to find a way to tamp down on the exposure to the first guy who gets it. And the only way that you can stay in business is to increase the price to everybody who takes the goods in subsequent iterations, such that when you sum them over the life of the patent, which remember now is mercifully short, it's only about 11 years typically, even for blockbuster drugs, you take all the revenues, they cover all your marketing cost, all your marginal cost of production, all your future liabilities, and also allow you to repay the debt on the capital with respect to the original loan, so that it makes your worthwhile to go back into the business in the first place. And I stress this capital because there are some supposed experts in social medicine who don't believe that capital cost ought to count. And I refer you to this dreadful article that Bud Relman and Marcia Angel wrote in the New Republic, and then later in a book, where she said it's all fictitious accounting to take into account the cost of capital for new drugs. Funny, it's about 11% per year given the riskiness of these products, and if you're actually trying to figure out what that front-end cost is of $1.3 billion or so, whatever the number you choose, about half of it is the cost of carriage, because you have to do all the basic research, then you got to go through all the patenting, then you got to go through all the clinical trials and all the approvals, and so you're basically running a cycle of maybe 12 or 13 years with expenditures all along the way, which can have to be recouped in this particular period. So the maxim is, this is a very large number, and the trick is, if you can't charge it all for the first customer, you have to backload it. And this is where the problem starts to come in. Everybody says, we agree that you have to backload the cost onto somebody else. And I think it's a wonderful idea if you look to the man to the right of me and you backload it on him, rather than backloading it on me. So essentially what happens is the backload problem is a very difficult question, because what you have to now be able to figure out is on whom the backload is going to take place. And everybody is going to try and say, I'm willing to pay the marginal cost, and I know I have to pay a little something towards the fixed cost of getting this thing up, but I want to pay as less as possible. So what you discover is there's a no unique allocation of the front-end cost once they move backward down the production cycle to everybody else. And there is now all sorts of games that take place, even before you get to global pricing, on the issue of who is basically going to be the guy out when you're playing the game of musical chairs. Everybody wants somebody else to pay those particular costs, and how do you do it? Well, it turns out this is a very complicated game, because now let me sort of just introduce another concept that you have to know to figure out what this thing is about, and that's called the notion of consumer surplus. I'm looking around the rooms, I'm seeing a lot of blank looks, so let me just see if I can, as it were, bring clarity to confusion on this particular subject. Basically, consumer surplus is the following measure. It's the difference between the amount that you pay for a drug, which is the bottom, and the amount that you're willing to pay for it. So if I'm willing to pay 30 for something and I only pay 10 for that particular situation, I've got a consumer surplus of 20. And if you start looking in competitive markets, every single person, with the exception of the last marginal consumer, has some degree of consumer surplus associated with the product in question. These demand curves slope downward, and what happens is if the market price is 10, there's some people willing to pay 11, some 12, some 13, some 14, some 15, all the way up to God knows how high until it's out there. And what competition will do, if you get new entrants and perfect substitutes, is that nobody gets any kind of the competitive surplus. It all goes to the consumers because it is competed away, to use the standard expression. But remember, drugs are more complicated, right? You've got all these situational advantages like we talked about in the hotel cases, but more importantly, which is quite different from them, every patented drug is a mini monopoly of one sort. Defined how? Well, legally it is defined as the right to exclude all others from the use or sale of the particular product during the duration of the patent protection. And that kind of gives you exclusivity. Does that give you monopoly? Well, the answer is maybe, because exclusivity can define both property rights on the one hand and total markets on the other. So if you look at Costa Sigler at 5807, is that it? 3? I don't know your address. 01. On sort of Blackstone Avenue, right? He's the only guy who owns that particular house, and so he's got a local monopoly. Unfortunately for him, it's not the only house in Hyde Park, and there are imperfect substitutes. So what we do is we have a form of a competitive market in which there's something kind of like what it is that one person owns, but not exactly like. The prices, therefore, don't perfectly equilibrate, but what happens is everybody kind of looks for that house which best fits their particular style, and you get this elaborate matching game. You've got 7 statents out there, all under patents. They're like 7 houses. And if you're trying to figure out how much monopoly pop you have in a market with 7 substitutes, we do know the answer to that question, and it's basically too small to measure. It becomes a competitive market, imperfect competition, very hard to get a super competitive rate of return. Well, that does not necessarily describe all these patents, because there had to be a first one in the statement class. Call it number X. And when he's getting out there the first time, he has no close substitute. He, in effect, can back down off this curve and act like a rational monopolist and raise price above marginal cost, and he could do it in one of 2 ways. He could either pick a sort of single number which is higher than the competitive price and charge everybody, and some people will be happy to pay it and others will drop out of the market. Or he could say, no, I don't want to do that because I know there are people who could pay $11, the competitive price is $10, and I'm charging $20. If I could figure out a way to charge them $10.99, I could get that as well. So essentially you get price discrimination in order to take advantage of the differences on these demand curves. Now this is essentially absolutely what drives all of the stuff with respect to drugs. Because the first thing that the pharmaceutical company faces is that it knows that the demand curves in Zambia are going to be rather different than those in the United States. And so if it decides what it's going to do is to backload the front-end cost of development on the local folks in Zambia, it's not going to work. They can't even afford to pay the 10 at the competitive price. They're going to need some kind of a subsidy in order to be able to get this drug. So what you have to do is, by definition, if you're going to backload, is going to have to put it on those particular areas where the interior demand, that is the demand that you pay above beyond the competitive price, is steep enough and high enough that you could actually recover those costs. And the market has to be large enough to be able to sustain it. And if you're trying to figure out what particular country is going to happen to have that particular characteristic in generally, it's going to be the United States. So that what typically happens in these things is they start working pricing strategies which have well above marginal cost prices charged in this particular country, to the great dissatisfaction of people. And what does it lead to? Well, it leads to efforts to do 2 things. One is to bargain the guys down. So it turns out when you look at the American market, you don't sell all of these drugs through the same kind of outlet at all times. They're very different situations. If some of you remember back to the good old days when the only thing we had to worry about was the bad Clinton Care bill, one of the provisions that it contained in 2003 was a provision which said that it's unfair to allow pharmaceutical companies to discriminate in the prices that it charges to any of the sort of retailers or middlemen or distributors or wholesalers or factors, whatever it is, to whom you sell this stuff. And who was behind this? Well, the answer is we know exactly who was behind it. It was the retail pharmacists, and it was not the HMOs. Now, why is that? Well, a retail pharmacist is sitting out there and he has to maintain a full cornucopia. Every drug that's out there, he's got to be able to stop for his customers. So when it comes to the great game of bluff as to who is or is not going to be able to sort of foist off a large portion of the extra cost of the first drug onto somebody else, these guys are in a very bad position to do that because they have to carry them all. On the other hand, if you're an HMO, huge volume with respect to purchases, and in effect you can say every one of my customers is getting Lipitor or every one of them is getting Crestor, you start playing these guys off one against another. And so what you start to see then is that there's a real amount of price discrimination. Well, how much? Well, one of the things you discover when there's price discrimination is that there's lying. We call these hidden or secret rebates. So that what happens is you go to one of these companies and you say, look, this is the deal. I'd like to charge you $3 a unit. He says, I can only pay $2.50. But I said, look, I really have to charge you $3 an hour, $3 a pill, because when I want to go to this other guy's, I said, look, I'm getting $3 from him. Well, you do the honorable thing. You charge him $3, and then what you do is you sell him something at a little bit of a lower price, or you give him a hidden rebate, or you give him free instruction. There are a zillion different ways that you can essentially disguise the fact that you're chiseling on the price to one guy, so you send out a false signal to the market, right, about everybody else, and you get them lowered. And then there's this learned debate. Do we allow rebates? The Chicago types, generally their argument is, what do you think? Yeah, you allow the rebates, and you allow them to be secret, because you don't know what the world is going to look like if you don't allow the rebates. And you're going to have to be able to police every other transaction, and if you can't give secret cash rebates and you've got this dynamic, now what you'll do is you'll give free instruction. You'll give them a good deal on some other drug and some other collateral market. There'll be something that you'll do, and you're going to have to expend the regulatory framework, and in effect, if these guys really think that the rebate is going to be the best tool to allow them to recover their consumer surplus, then under these circumstances, we ought not to fiddle with them any more than we ought to fiddle with the airline or with anybody else. And so what you do is, under the sort of relatively unregulated market, you get yourself this incredible kind of scramble with respect to prices. Well, somebody now is going to be there at the $3 line, and what he's going to try to do, he's going to try to get himself some alternative source of supply, because he's got somebody who says, no, I'm not really going down for you. And so you start seeing noses wag, and what do you start to do? Well, for the one thing, you say, you know, I got these other competitors, and one of them is a generic. I don't think it's quite as good, but if it's a question of paying $1 to the generic or $3 to this guy, I'd rather do that. And so what you do is you start to see the erosion of the monopoly position of the market, which forces the prices down further, which means that the presence of generic competition makes it harder to get the next drug in there by way of a new innovation. So there's a very complicated question as to how fast you want these generics to come in, because they may kill new markets. Then, of course, you're going to come back and tell me correctly, of course, that the difference between the generic and the branded drug is not nearly as great as you thought. And then somebody else is going to come back, but you didn't look at this 20% of the population where, in fact, the opposite turns out to be true. And it's manana land. The conversation just keeps going on forever. So what happens is there any other way that you can cheat if it turns out that you want to keep exactly the same drug? And what you do is you engage in what we call arbitrage markets. You all know what arbitrage is? Essentially, arbitrage is an economic phenomenon, most originally devoted in financial markets, where you buy cheap in one market and sell dear in another. So the arbitrageur is a person who takes two markets that look to be relatively separate, and by buying in one and selling in the other, he bids up the price in one, lowers the price in the other, such that the two of them become into equilibrium. And generally speaking, we like arbitrageurs precisely because what they do is they make markets more efficient. And the question you have to ask about an arbitrageur, in the simplest terms in the financial markets, is as follows. How small a spread can you sustain and still be into this business? And the most striking things about these markets and their efficiency is that the fractional differences that get eroded by good arbitrageurs go down from 1 or 2 or 3%, which they were in the 1980s, to 0.01% today, or something like this, on large amounts of financial stuff. And of course, if you stumble just a little bit on that kind of a margin, you can look like AIG or some other of these benighted corporations. But essentially, arbitrage is a key feature in these markets. Now, where is there an arbitrage settlement competition? The answer in pharmaceuticals is everywhere you look. Now, why is that the particular case? Because if you now want to talk about these drugs in terms of a global market, right, instead of in terms of a local market, what you discover, in effect, is that every country on the face of the globe knows either intuitively or explicitly the great difficulties associated with the marginal cost problem, and each of them wants to pay as little as possible. And the way in which you do that on your side of the market is to organize, so that if you're the British, you do not allow a bunch of people to go out there and bid separately for drugs made overseas, because that particular competition between the rivals will result in bidding up the prices that are prepared to be paid. So what you do is you establish some kind of a national authority that bids on behalf of all of your worthy citizens. And if you look throughout the EC, essentially that turns out to be the dominant practice. You look anywhere else, it's the dominant practice. Now, if this were an antitrust universe governed by American laws, this would be called a monopsony. A monopsony is essentially a monopoly amongst buyers, or a cartel amongst buyers. It would be a per se illegal offense. But one of the things you discover about international law is that the antitrust consumptions have no traction whatsoever. This is basically the law of the open market jungle. Everybody can organize in whatever form they see fit. And so what happens is these countries now try to create a situation in which they can get drugs for themselves at very low prices. And so you see the price discrimination working in advance. And then there are other places like the Zambias and the African countries in this world where even if they organize, they'll drive it down a little bit, but in a straight competitive market, they don't have the money to bid it up. So that you can find 3, 4, and 5, 6-fold differentials in price in various places across the world. When you start seeing a 6-fold difference, and you realize, in effect, that the institutional barriers are such that on the American side, we don't wish to lower the prices because we got all these domestic companies, and on the foreign side, they don't want to raise these prices, you have to assume that arbitrageurs are going to have a field day. And this then leads you to another very powerful phenomenon that you have to worry about in these prices, which is essentially the cross-border trade or the parallel trade of one form or another. The form in which you are most familiar with this, I dare say, is in connection with the flap-over arbitrageurs between the United States and the Canadian markets. And it's not the only place that it exists. And let me explain to you why it exists, and why it is in the end that the pricing differentials aren't going to be quite sufficient to carry the day. This is, I think, if you were to look at the markets, this was probably a bigger and a liver issue in 2004 and 2005 than it is in 2009 and 2010. And in order to do this, what you have to understand is that the arbitrageur has multiple incentives. One of them is, of course, to buy cheap and to sell dear. Another is, if you can get the right guy, is to sell some bogus product dear, having not even bothered to buy the darn thing cheap. And the difference between the American and the Canadian markets in size turns out to have a profound set of implications on both the pricing and the inspection side of this market. Roughly speaking, for these purposes, the difference in size of the two markets is sort of in the order somewhere between 12 and 15 to 1, which is a fairly different size. The population differences are about 12-fold and so forth, and if you take into account consumption intensity levels, it may boost it up a bit more. Well, you start running a huge differential on that particular score. What happens is somebody has to inspect these drugs. And so the American model was, what we will do is we will send our people to the Canadian pharmacies, buy it there, and ship it back into the United States. And the low-level bleed is the informal arbitrageur. My cousin Sadie happens to live in Montreal. I'm going to go visit her this weekend. I'm going to come back with 2 months' supply of X, Y, and Z drug. The large firm is that, why do we wait for Sadie to come there? We'll just get somebody to ship it on bulk and then sell it to pharmacists and so forth. American companies, of course, go absolutely apoplectic about this, and their attitude is, we have a patent in the United States. If it's an exclusive right to sell in the United States this particular drug in question, anybody who deliberately imports into the United States and sells a patented drug without our blessing and approval is a patent infringer. And so therefore we're entitled to stop these things. But of course, that presupposes you know something about patent law. And if you don't, what happens is it's very complicated, because there's also in patent law something else known as the first sale doctrine. And what this doctrine says is that your patent protection only applies for the first sale, and after that it doesn't apply to anybody who resells the thing. So that if you applied this first sale doctrine, the first sale is to the Canadian pharmacist, right? The second sale is in the United States. And so the question is, if the first sale doctrine applies, it means that the patent protection is eliminated. To which, of course, there is another counter-argument. Well, I mean, look, you know, each one of these little curlicues is worth maybe $10 billion a year. So, you know, got to be patient with them. It is obnoxiously difficult and slightly crazy, which says you cannot use the first sale doctrine in an arbitrage situation between different markets. Because we don't have any control over the price there. So then what you try to do is to figure out how you can get around this particular thing. And one of them you say is you'd like to impose a covenant upon the party who first receives the good that he agrees not to sell it at a higher price to anybody else, and if he does, he will transfer to you a difference between the price that he sells it at and the price in the American market, so that essentially he has to sell it at the American price, the market will start to shut down. Well, that's a very clever argument, but the issue then is, if you have a first sale doctrine, can you have a covenant that restrains alienation in this particular fashion? And the literature on that particular position turns out to be very sharply divided. Recent Supreme Court cases, mostly badly reasoned in my judgment, say that you can't use these kinds of covenant situations within the United States, which leaves it open as to whether or not you can start to use these kinds of situations in international markets where the risks are much more dangerous. We don't know the answer to that. Well, that's one problem with respect to arbitrage, but there are other problems that make it more difficult. Canadian government gets wind of this stuff. And what's its particular attitude? It's going to run a very rigorous inspection program for Canadians. And by the way, inspection, if you don't know it, is a very serious issue today, because the incidence of fraud in one kind or another with respect to drugs may cover as much as 10% of the market. And you don't know which 10% of the market it is. And these are not guys who are trying to sort of sell you knockoffs and announcing them as such. This is what we call hardcore pornography. What they are just doing is they're taking your thing, they're putting it into your boxes. What they're not doing is putting your drug into there. You're sitting there and somebody says you took a Pfizer or a Merck or an Upjohn product, whatever it is, and it didn't work, and you're going to sue the company for something that it didn't make, right? This is a very serious liability issue and so forth. All of the tracking devices, the recording devices, the coding devices that are now introduced by these companies to fight it is enormous. There's a huge border authority which is allowed to confiscate things that are misbranded as well as adulterated, one on the safety issue, one on the trade issues. The two of them turn out to be very heavily interrelated, because the odds that a misbranded drug will be of comparable quality to a correctly branded drug is very, very low. Guys who are willing to cheat in one domain do not all of a sudden turn out to be health nuts with respect to another. I mean, they're willing, if they're willing to steal from you, they're willing to kill from you. I mean, it's essentially what the basic maxim in this area is. And the Canadians know this. But what they now do is they announce a rule, and what the rule is that they will inspect only those drugs which are bound for use inside the Canadian market. So you want to start playing the export game to the United States, somebody else is going to have to do that inspection. That's going to be the United States. We start trying to figure out, now, how are you going to do that inspection when you don't know where they come in there? Buyers all of a sudden become somewhat unnerved by the prospect that what they are going to get is Ersatz good. So that's the second. So what you then do is you say, well, we could solve all this problem. We'll just bring the FDA to the rescue and have them do this. But this turns out to be extremely difficult. First of all, the safety inspections are very serious, and in order to do this, you have to have FDA people going into plants all over the world to see the way this stuff is done. And if you're correct on inspection, there's something known as a whole chain of custody. Are you familiar with this term? Any one of you who's ever worked in security stuff will realize that the weakest point in the chain of distribution is the place where the falsifications will start to take place. So you have to keep this thing absolutely under scrutiny and seal every single step of the way, lest this happen. And what happens with parallel importations, if you take a drug from the United States, send it to Canada, and send it back, that chain gets a lot longer. The burdens that are put upon the public bodies are greater. Make it even worse, it turns out it's not the same drug. What do I mean by that? If you're selling a drug like Lipitor in Canada, maybe you sell it in 25 and 75 milligram tablets. In the United States, you use 20 and 50. The rule that the FDA has is, in effect, that you can only import into the United States for sale here drugs which are in the same quantities which those are approved in the United States. We don't want to allow this kind of circumvention. So one of the things that was proposed in order to deal with this thing when it came up before Congress several years ago, I must confess, with great pride that I worked for the pharmaceutical companies in an effort to derail this monster, was that the guy who held the patent would now be under a duty to file new applications with the FDA to make sure that the imported drugs from which it got no revenues met FDA standards, right? I mean, involuntary servitude is a perfectly apt description for this, and it didn't go through. But in the end, what happened is the arbitrage law situation got tied up in patent issues and FDA issues, pricing issues to be sure, potential kind of contract disputes. But what killed the market was the perception that these drugs would not be safe. There is a memo, which I'm sure you could find on the Pfizer site, and it's basically entitled 28 Ways to Adulterate Your Favorite Drug. I mean, and it just really, it's amazing what you can do when it comes to doing these kinds of things. So that becomes part of the problem. So if you're not going to have importation from Canada, you're not going to take it from Zambia or Zimbabwe or wherever else it turns out to be. And so the arbitrage jour situation remains important, but it essentially does not remain finished. Where does it remain? It's still a problem in many other places. For example, here's another difference. I don't know how long you want me to talk. Another 10 minutes, 5 minutes?
5 minutes.
Okay. There are other places in which you have exactly the same kind of problem with respect to this stuff. And one of the areas in which you deal with global pricing is the one that I've mentioned. This is not how you get drugs cheaply into the United States. This is how you get drugs at all into a place like South Africa where they're needed for AIDS. And I can't tell you how many sessions I've been to here and everywhere else where indignation reigns supreme with respect to the slow transmission of drugs from the developed countries to the undeveloped countries of the world. Everybody who makes this claim has a point, and the point quite simply is if it costs you $100 to make a supply of AIDS drugs for a month that will keep somebody relatively healthy, or $1,000 a year, and you benchmark that against the life that you're saving, somehow or other $1,000 doesn't look so big, even though to a company who's going to have to do this 100,000 times, it turns out to be a $10 million hit or something of the sort. Question is, how do you get these drugs in there, and what are the difficulties associated with it? And this is, I think, the basic point. Every drug company with which I have spoken, it's a fair number, has the following attitude on this. We are quite happy to send this stuff off at marginal cost, which is close to zero. And in fact, you can get it to zero. All you need to do, since money is fungible, is to have the Ford Foundation go to one of these companies and say, we know it costs you 25 cents a pill. We would like to have 100 million of these pills. Here's $25 million from our Putschke. We'll take the stuff and start to administer it. And the drug companies would be delighted to do that, except, and this is the great problem that you get, and it's a pricing problem, and it's a safety problem. On the pricing side, the moment you send some of these perfectly good drugs into a warehouse in Cape Town, it has a 50% chance of being stolen. And if it's going to be stolen, it's going to be resold in the German or the American market. And in this case, people may well be able to validate that fact that it's a good and clear drug. So that unless you could stop that particular stuff, it's a problem. It's even worse, because the person who may well steal it in any one of these nameless companies could be called the Minister of Health. Because the level of corruption that takes place in some of these markets is really quite rampant. And so the companies say, we'll sell it, but only if you could give us arbitrage protection. And can you do that? Well, the answer is you can, but it's very difficult to do. What you have to do is transform yourself from a modest drug company into a drug delivery system. And what that means, in effect, is somebody has to go to one of these countries like South Africa, keep possession of the drug from the day the thing was put out to the day it's done, and actually apply the vaccines to the individuals needed so that it never leaves their control. So that essentially the way in which you stop the fraudulent arbitrage game is to vertically integrate downward to cover all of the service distributions. And this exists in the United States today for a number of drugs, right? Where if they're really dangerous and somebody's worried about the fact that there's going to be an overdose, you do not give it to them to take it at home and watch them clue themselves. So I've known some perfectly intelligent law professors who think, these doctors are a bunch of chickens. Whenever they diagnose X, I'm going to give 2X and take it myself because I'm a strong guy and I want to get done quickly. I know you just don't. That happens all the time in drugs. I mean, with some of my friends, I might add. You can't do that. You just have to go there and essentially administer the thing. That's real easy, right? You take the drug and you administer. No, it's not real easy. Now try doing this in a place where there's no refrigerators, right? And you have a drug which essentially has to be kept at constant temperature between 42 and 44 degrees. Otherwise, the thing degrades within 12 hours after it's off ice, right? try to meet that condition down there. So what you have to do is to build up the entire system. This turns out to be very expensive. And the key thing to understand is that these costs have to be incurred by the generics as well as by the branded companies. And the branded companies, are, if they can sell it, are more likely to be willing to incur these costs. The generic companies are generally just not built for speed. And so you have this terrible problem of how it is that you organize a distributional system with these things, given the fact that you have to vertically integrate downward. If you don't vertically integrate downward and somebody gets hurt in South Africa by taking one of these drugs, there is a credible lawsuit, I am sorry to say, but credible nonetheless, that you can sue the company in the United States on the grounds that it was improperly distributing the drugs when it gave it to a party whom it knew or had reason to believe would not be able to treat it in a fashion which was appropriate for distribution. This is not a wildly difficult theory. So the companies, in effect, are frightened about the liability risk. So now you're the Ford, the Ford Foundation, you want to pay for these drugs. Marginal cost isn't the price of the drug. Marginal cost is the cost of running this entire system. And the only way you can do it efficiently is to create some kind of consortium, so that you handle all the downstream stuff for all the drugs and all the companies simultaneously, and at that point you run an antitrust risk, right? Because now what you're doing is you're colluding in the distribution of a non-profit item, and there's enough loopiness in the antitrust law that no general counsel is going to sign off of that unless they get an opinion. And from the current Justice Department, who knows whether you're going to be able to get it or not. And if you get it from this one, who knows when you get the next administration in whether or not this thing is going to be revoked, and you're going to find yourself up the creek. So in every one of these markets, it's just an extremely difficult feature. And what do I think you ought to do? I got to get a punchline somewhere here. Is I think in general the effort to try to handle this problem by regulation on pricing is going to be a mistake. You just got to let this thing kind of roll. If you think that there's an arbitrage or opportunity, what you do is you try to talk to the foundation, the pharmaceutical companies, get the foundations in, get Doctors Without Borders or some organization, and let them do it collaboratively rather than coercively. Where you really have to be tough is on all of the safety issues. Because if those are allowed to take hold, then nobody, rich or poor, will be able to tell themselves with drugs. And this is essentially another model of what I regard as the Chicago School of Regulation. And it's a sign of cowardice and therefore of wisdom, which says go after the low-hanging fruit. That's a big problem, and that's the safety issue. Much higher rates of return on that than in any investment on the pricing stuff. And so what you do is you let this thing unfold, understand that all of the arbitrariness, craziness that you're seeing out there is a function of the fact that the moment you are in a world with marginal cost controversies, right, how you allocate the cost of the first drug across all subsequent uses, that's going to be somewhat arbitrary. My arbitrariness is not better than your arbitrariness under the circumstances. There's long-term productive gain out of this crazy melange. Don't let yourself get upset about the visible stuff. Understand the deeper origins for the problem and realize that whenever you're dealing with pricing of a high fixed, low marginal cost drug, you're always in a world of the second best. And so, in effect, it's an argument for realism on this particular point rather than for moralism. And on that happy note, I'm happy to take any fair questions. Thank you.
Is it?
You can ask a question. Just make it good.
Is it? I hope it'll be fair. Is it the case that if you did not have this concern about safety with the reimportation of drugs from Canada, that essentially it sounds like it is enough of a concern that it's shut down that that transfer? Wouldn't the companies in the U.S. basically demand the Canadians to pay more to the point that they found their equilibrium where, you know what I mean? Why would they not just say, if there's a lot of this transfer in Canada's population,
just pay more, right?
Yeah.
Well, there's a hook here. And let me tell you what happens when somebody made that clever suggestion. Canadians come up and they say, we have a doctrine in Canadian patent law that if there's a refusal to honor honorable prices, what we'll do is we'll invalidate the patent in Canada and allow a generic producer to come in and to make the drug instead. Right? Now, you could go back and you could look at TRIPS, that is a trade-related intellectual property agreement, and ask whether or not this falls within the necessity exception to the patent protection. I would say no, and I'm in a minority, because the number of people who essentially believe Marginal cost pricing is ideal, and therefore patent destruction is appropriate, is very, very large. The number of people who are willing to sort of take the grand distant view, like myself, are very few, it turns out, in the business. And so that threat becomes part of the negotiation, so you can't do it. What you do try to do, and what the Canadians will yield, so you try to get quantity restrictions on the amount that you sell there, right? But what happens is they are frightened to death. If suppose you get 90, you say, look, you know what your capacity is, it's 100%. Put it out for sale in the pharmacies. And all of a sudden the leeches come in and 15% of it is actually taken to the United States. Now they've got a shortfall. And so that gets them very, very nervous about this, because what happens is it's very difficult for them to be sure that when it goes for sale in Canadian stores, it's used for Canadian patients for Canadian reasons and so forth. So the separation of markets is extremely difficult. So what you do is essentially there's a classic, you know what a bilateral monopoly is? I got a high price, you got a low price. It's one buyer, one seller, and the buyer is willing to pay up to $100 and the seller is willing to take as little as 10. There is no unique point in between where you discover the price, all right? That's what you get. That's essentially the back-end problem with the marginal cost controversy. Only it's worse than that, because you now got all sorts of collateral threats so that you're not quite sure what the range is, because these other terms like patent nullification and so forth can come in. So it's a very rugged business. Yes?
So you're proposing that the only reason that the pharmaceutical industry is not supplying drugs at marginal cost to third world countries, for example, for AIDS, is because of fraudulent arbitrage. They're concerned that that's going to happen.
I think it's the dominant one. Look, well, the other thing to understand about this, to put it in perspective, is that currently in a place like Africa, about 95 to 97% of the drugs that you need are off patent right now. And there's still systematic shortages. So it can't be this price. What happens is when you look at the generic market, it too is much more complicated than you would think. And in many places what happens is if the generics come in low, there's a local cartel which is designed to try to extract the rents at the consumer level. And so if you go to a place like France or Germany, it turns out you have these little pharmacies, right, with their little green crosses, and they're very specific territories, and you're not allowed to open at will a new pharmacy in any location, and we cannot start Sigler Incorporated bargain basement online pharmaceuticals or sell them at Walmarts or whatever it is. And so what happens in those countries, the basic distribution of prices is, since they have much worse distribution systems than we do, the generics cost more there than they do here. When you get to a place like South Africa, you still have to face the distribution problem. One of the advantages of having patented drugs over generic drugs is, since their margins are larger, they are often willing to build distribution systems if they're given sufficient clout and freedom to do so, whereas the generic guys are not. What is happening, therefore, in the industry is there's now some kind of weird consolidation in which some of the branded companies now take back licenses on generic drugs. So once they build up this infrastructure, they can put this other stuff in there and charge the other guy only marginal cost for the purposes of shifting them there and split their fixed costs. So there's just a lot of effort to try and do this thing down. But the part of the story which I think is legitimate is that this is not simply just a question of greed. There are too many other issues going on there. And it's the fraud, it's the liability stuff. I mean, it's just a lot of things that are happening. And when I speak to these people, they sit down, they always do it. They said, you got your problems, we got our problems, right? And I listen to both of them, and I'm like the rabbi says, you got a problem? I think you're right. He says, you got a problem? I said, you're right too. The third guy comes along and says, Rabbi, how can they both be right? You got a point. You're right too, right? I mean, what each one does is they point out the difficulties on their own side and the opportunities on the others, and both of them are right that the difficulties on their side, and they're right that there are opportunities on the other side. The problem is when you sum up the opportunities, they don't cover up all the difficulties, so there's always a shortfall. And I mean, particularly in some of these countries, trying to work through local governments. In South Africa, it's been just a terrible problem, figuring out distribution plans along the way, getting cooperation, getting people who just stand aside, getting people who cooperate. It's a very, very difficult market. I mean, any perishable is hard to shift through interstate commerce and harder to ship through international commerce. Well, this is why it is, by the way, in the patent world, things that you might think to be small in the context of America loom enormously large in the context overseas. So getting a drug, for example, which you can administer once a day instead of 4 times a day, and you're trying to figure out how that works in a Saharan clinic, it's a difference between life and death. Two things. One is you can see 4 times the number of patients as the first approximation, and you're going to have 1/4 the errors with each of them. You know, trying to count to 4 when you're talking about the administration of drugs is no small deal.
One that doesn't need refrigeration.
Yes. I'm saying all of these things, no refrigeration, putting it in solid instead of liquid form, getting a container, which is whatever it is. It turns out every single one of these advances in delivery systems, which are valuable in the United States, are exponentially valuable in places where the downstream control is much more fragile.
Can I follow up on this question?
No.
As a strategic maneuver, why would, for life and death diseases like AIDS and malaria and things, why would it not be to the advantage of the pharmaceutical industry in the U.S. and Switzerland and France to subsidize generic manufacturers of their on-patent drugs? Why don't they turn over to the generic manufacturers all of these problems that you've talked about? The distribution problem, the liability problem, the fraud problem. That is, we've done our bit. We're not going to make money in Zambia or South Africa very much from our drug. We're worried about the reimportation.
Yeah, I mean, and the answer is, I'm willing to dump liabilities on anyone who's willing to take it. You've explained to me why it is the big companies want to get rid of it. You haven't explained to me why Teva wants to take it on. I mean, Teva says, well, we got this wonderful opportunity. We can make $100,000 selling a drug and get $10 billion worth of liabilities. It's exactly the opposite way. It turns out that the only companies that get enough revenue out of these drugs are, in fact, the branded guys that have some monopoly position.
Is that right?
And so they end up taking over the generic distribution system. So it goes in reverse. You're right to say that there's some synergies, and then for all we know, you take it over and then you hire from Teva the one guy who did sub-Saharan distribution and have him to work for you. So instead of doing it by merging companies, you get joint ventures, you get hiring arrangements, you get anyone or all sorts of these kinds of adjustments. But my point about this is not to give you the ideal solution, which I don't have. I have some sense of the trends. It is just to sort of stress just how difficult it is to run one of these systems when you, first of all, understand that the pricing models are extremely difficult and the safety and the patent issues that come on top of them are extremely hard, and the control and the corruption issues and the international trade issues are very hard. This is an industry which has to work very difficult. Now, how is it doing generally? The answer is it's not on life support. I mean, but it is, as best I can tell, the salad days are behind it. Yeah, I mean, having looked at this, I mean, let me just sort of give you the rundown, okay? First of all, on liability, catastrophic results in the United States after Wyeth and Levine. This is Justice Stevens at his negative IQ highest. In which what you do is you have a drug, you know, this is the Phenergen situation, perfectly well marked, misapplied by a doctor, physician assistant, who doesn't read the label, doesn't know the difference between a venal and arterial infusion, too much, too fast, too soon. And what the doctor and the physician assistant do is they settle out cheaply with the plaintiff and they sue the drug company for failure to warn and failure to package and failure to do this. And the Supreme Court says it's just fine to let these suits go through. So, essentially, at this particular point, there is no warning you can devise for a product like Prozac, which will, in effect, insulate you from the possibility of liability. Under circumstances where the causation issue is you're probably reducing the overall probability of a depressive act, then you have two problems. One, if you actually create a 5% risk to stop a 50% risk, are you going to be liable for the 5 and get no offset for the 50? Or is it going to be confused that you think it's the 5 when it's really the 50? So, for example, in the wild strain cases with respect to the Sabin vaccine, Paul Meyer, who used to be here, and is no political conservative, said he did a rough calculation, says it was 1,000,000 to 1 likelihood that it was the wild strain rather than the vaccine which hurt the girl. But this was now a jury question as to whether or not you could find one or the other liable. So you've got real problems on the liability stuff. And in the international market, these suits can come back to the United States in many ways. The venue jurisdictional issues are very complicated, but there's no safe harbor. All right, so you've got liability. Pricing, we have Obamacare. Now, you may not think about it in this particular situation, but it's very clear that there are implicit price control mechanisms built into the statute. which will take place by way of indirection. That is, the way in which it works, and this is going to hit all of you people very hard, is that the insurance companies will be told by the state regulatory commissions, we assembled this data, we don't like the way it looks. They send it over to the federal government. The federal government says there are excessive profits here. They send it back to the states, who can then decide to give a haircut to any one of the insurance companies, which means that they're going to give a haircut to any one of the hospitals that they have. So the pricing system will be completely chaotic by the time this thing goes. And this will not be chaos of a discriminatory ways of getting people in the market. This is basically pretending that everything is a monopoly profit and that administrative costs are all illegitimate. So what's happening, the companies all know this is coming. Every one of them are reclassifying expenses which used to be regarded as administrative, and they're now calling them medical. And so they're saying, hey, we meet all of your quotas. And then what will happen is somebody says, you just made this opportunistic change, right? And so we're going to disregard it. Then you have to litigate this thing. But you have to do it not for one company. You've got to do it with respect to 80 or 100 or 1,000. Oh, let me tell you, I feel like a very rich man after this statute passed. I mean, I can't tell you. The dough is just going to roll in. When you say, but you guys are going to pay me. It's crazy. So you get very serious pricing issues that you have to face with this. You have very serious patent issues at this particular point in the industry. Essentially, the erosion of patents on some of these incremental improvements we're talking about, solids versus lytics and so forth. Much more willingness to find these things as non-patentable, non-obvious, whatever it is. So your patent stuff is surely weaker. There's nothing that I'm aware of which has gone stronger, and the remedies are weaker. So that's the third area. The advertisement stuff, it seems clear they're starting to clamp down on that. FDA approval stuff, I don't even want to begin to talk about those yokels. But it is clear that the cost is going up, the delays are going up, the fractionals groups that you have to be able to test on are smaller and smaller. The ability to put all this stuff together gets weaker and weaker. There's going to be a real constriction inside the basic flow because of this. And there's no sympathy whatsoever in the organization. I've actually followed some of the refusals on safety grounds, which I regard as preposterous. Extrapolations of very high concentrations in rats to very low concentrations in people of drugs that have already been used in similar concentrations, and you find a safety risk on the new one which you don't find on the old one, even though it has other advantages. So I mean, this is an industry, at least domestically, has real problems that it's going to have to face. And the question is whether or not the technological improvements in the expanding old age population will be enough to offset this. And the answer is yes, in part. But you already see constriction. Remember, Pfizer closed its famous laboratory in New London. Now, why did it close the New London laboratory? Because they ran out of the tax subsidy. But they also merged with Wyeth, and they had one in Groton, and the business is no longer big enough to support 2 research labs. Only big enough to support 1. I mean, the company essentially is going to lose $13–14 billion a year in Lipitor sales sometime in the middle of next year, and it doesn't have anything in the pipeline which is remotely capable of doing that. So you're taking a $60 billion company and making it into a $35 or $40 billion company. You know what? $35 billion is a big company, but it's not as big as $60 billion. And you're going to see all sorts of slowdown. So this stuff is just part and parcel of the larger kind of picture in which I think that the demand will keep going for a while. And so what I do is I kind of anticipate that you'll see this as a non-growth area with basically stable earnings, not catastrophic, but this is not like an industry that was poised for expansion in 1980 when we finally got the patent stuff organized in a coherent fashion. You could see investment in these drugs going up exponentially. Amazing what happened. Yeah?
Hey, could you comment a little bit on the sort of problem of Me Too drugs?
What was that first word?
Me Too.
No, I know the other word.
Problem.
Talk about the phenomenon.
Phenomenon. Yes, could be. Yes. In the sense that drugs come onto the market where the R&D costs can't be as great because they've already got a drug that somebody else had created. They change just a little part of the molecule. It doesn't seem to me when those drugs come onto the market they actually decrease the costs of overall. They really rise to the level of the pre-existing drug that was on.
Where did you take your economics?
Excuse me?
Where did you take your economics? You're the first person who's ever asserted what was always thought to be wrong, that a duopoly can maintain higher prices than a monopoly, right?
Yeah.
There's a model by a man named Cournot called the Cournot duopoly model from 1838. Get two drugs into a market, and you could literally trace the equilibrium position in the decline. By the time you get through 5 drugs in a market, you can't tell the difference between empirically that and a competitive price. So that's wrong. But let's just go back to the problem.
Yeah, and
the Me Too drug.
Yeah.
Essentially is a drug which is purported to be a substitute for a drug which is already out on the market. And the advantage that it has in terms of its cost of production is that there's some imitative learning that can take place in virtue of the fact that you know the general properties of statins are COX-2 inhibitors. So what happens is when you start your research, you go a little bit faster. It's also the case if you look at the patent law, the disclosures of the previous drugs on the best mode of production, which is a requirement of a patent, will help the next guy come across and reduce his cost, get it into a market. There are 2 ways that could work, and both of them are wonderful. One of them is it could be a perfect substitute for the first drug. Now you got a duopoly, unambiguous price reduction with respect to consumers, because these 2 guys are going to be fighting with one another, and if they talk to each other in order to collude, they get treble damages under the antitrust laws. It should. The patent system is designed to give very large rewards to the first entrants on the hopes that that will induce a close competitor to come in with a rival patented or non-patented technology. So if they're the same, the second guy who comes in effect, will erode some of the monopoly surplus of the first guy. There'll be a little bit more by way of cost of production. That's bad. But there'll be a greater savings of what we call deadweight losses. That is the inability to make sales at a high price that you can make at a lower price. And if in every other field we regard this as an unambiguous good, the 2 drugs are completely random in terms of their allocation. Now, they're not going to be that way. So you may get 10% or 12%. This is a very substantial situation. And to be against Me Too drugs under this circumstance is like saying, well, the year's 1923, we've discovered insulin, we give it to people, we discover that 85% of the population do just fine when we zip it into them. Who gives a damn about that other 15%? But essentially, if you actually figure out what the history of whatever it is that you guys talk about with diabetes and so forth, hormones, whatever it is, most of the work has been trying to figure out, A, to improve delivery for the first group, right? And to get that second group, which is somehow or other deviant and aberrant. And we spend an enormous amount on those things. And that's exactly what you're doing with these drugs. You want broad spectrum stuff. You never want to put yourself. Now, it depends. With things like Lipitor, you're not dealing with evolving ordinances in response. I mean, it's as good 10 years from now. Now, you start dealing with anti-infectious agents and they start getting these modifications. There's no such thing as a Me Too drug. You want to get some other mycin out on that market as fast as you possibly can. So, I mean, when people do it, there are either 2 variations. Either it's different, at which point it's fine, or it's not different, at which point it's fine. So it's not a problem. It's what we call an innovation. And that's the way it ought to be treated. And, you know, the single dumbest proposal, the many dumb proposals that have come forward, which was again in the Marcia Angel drug, is, and the current FDA seems to be willing to buy into this, is that their job is to sort of test efficacy against the current drug rather than against a placebo. And what this means, in effect, you now got industrial policy. These characters are going to decide which of these drugs have a niche and which of them do not. Their combined intelligence on economic issues is a negative. I mean, they don't know anything. Quite literally, the level of ignorance is simply stupefying for somebody who comes to this as an industrial organization lawyer and economist. They don't know anything about the subject. And if you now prove that this drug is not effective because one drug costs 60% and the other only takes care of 50%, right? What you're doing is you're missing the heterogeneity problem entirely. So the right thing to do is to let them in there. Indeed, I think so little of the FDA. This is being recorded, isn't it? I think so little of the FDA that after phase 1 trials, I don't want them doing anything. I mean, because all this stuff then is these 2 things. Every single large consumer of drug does an effectiveness survey before they get the purchase. So it's simply repetitive. And on the safety issues, it turns out we know from the demand for experimental drugs that if you keep them off, a drug precisely tailored for one condition will not get on the market, and a less than perfect off-label use of another drug will be its substitute. I just don't understand the logic of all this. We have time for one more question?
Yes. Is there, if there's not, I'm going to ask a question unless I see a hand.
Come on.
Last question. If the last 100 years saw a pharmacologic revolution unlike any in the history of the world, what might incline the next 100 years to be as innovative and as progressive as the last 100 years?
Well, at this point,
Everything you've told us will move us in declining. The slope is going to drop on innovation.
Well, okay, first of all, one of the things is independent of regulation, the slope will drop because you got the easy hanging fruit. I mean, most doctors have heard of something called pellagra, right? And you know about the very complicated treatment that is needed for it, the way you put people in intensive care units and feed them a carrot. Right? I mean, the first round of vitamin deficiency drugs were cured by diet. Right? There's nothing you're going to cure. Alzheimer's disease, bottled water, not going to do it, right? So, you're really going up against much more complicated disease constellations which come later in the cycle, which exist precisely because all the easy ones we've now managed to cure. And so if you look at the killers of 1900 to 1910, they're gone, one after another. I mean, so forth in numbers. And it's amazing how easy it was to get rid of them. This is reflected. The cycle between 1900 and 1950 in terms of life expectancy was roughly speaking 47 to 65 years of age. In the last 50, 60 years where we spent, 1,000 times as much, we've probably been able to push it up from 65 to 77, 12 years as opposed to this. Now, mind you, it's an extra 12 years. It's harder to do than the first one. But even if you correct for that, the rate of return that you get on the new investments have been vastly lower. And there's just no way you're going to find another pellagra and another carrot. I mean, it's just not out there. The problem about you guys is you know too much. You're too smart. So it's the question of how you deal with this other stuff. Well, this is a much more complicated market, and it's going to have to face all of these problems, and you have a group of regulators who don't understand it. Absolutely from top to bottom. I can't think of a single time I've spoken to somebody at the FDA whom I said, oh my God, they really understand how this system works. Every time I go to them, I'll give you an account because it's on tape, right? We ran a conference on oncological drugs at the American Enterprise Institute, and we had all these ex-FDA commissioners hanging around and talking with us, and von Eschenberg came for lunch. And this is the way in which we solved the medical problem in the United States. He said, in a 20-minute speech, the first 15 minutes could be summarized as follows. The FDA loves patients. The doctors love patients. The pharmaceutical company loves patients. Everybody loves patients. We're all in this together, so let us do what we can to help the patients. I'm retching in the audience. I don't love patients. No. He's got it exactly right. I hate mankind. So I asked him the following question. I said, I was here this morning and you were not, and I listened to a bunch of docs talk about various clinical studies, and the consensus opinion, which is the same consensus opinion in this room, is that given the peculiar definitions of what counts as research and so forth, FDA oversight slows down medical research developments by 3 to 5 years, 2 to 4 years. You pick the number. I've never heard anyone say less than 2. Nobody's been extravagant to say more than 5 or 6. I mean, that seems to be a consensus band. I said, and when we started the talk this morning, that's what we heard. I said, what are you going to do about that? And this is what he said. He's so good. He says, I want you to know, I'm so glad that you have the interests of patients at heart. So you can deal with this problem along with the doctors and so forth. Now, why did I ask that question? I didn't have any clients in the room, right? You go up to the front of the FDA and say, you are the biggest collection of intellectual clowns known to mankind. You won't do it. This is, again, 35 years ago when I was a cub going into this thing, somebody started to tell me about the difficulties they had with the FDA guy on beta blockers. They said he was a real moron. This stuff is being used everywhere else. And so I said, just expose the fellow. Just announce him as a fraud. You're true, right? They said, of course it's true. Then somebody looked at me and they said, Professor Epstein, you do not understand the way in which the world works. I was a professor then, but very naive. He said, we have 35 products before the FDA. We may be able to get this one through with denunciation, but we will get new requests for additional information on 34 other drugs within 24 hours after we make this denunciation. We prefer quiet diplomacy to a bloody but futile assault. That was essentially what they said. Now, that is exactly true. So after these things went on, what we did is we had a panel the next day of all former FDA commissioners, each of whom were angling in some way or another, and they spent most of their time denouncing me for my proposals to make sure that they were members of the fraternity, which is an important thing to do. Look, this is an extremely difficult thing to fight. And, unfortunately, doctors are in charge of global health issues. And this is a tragic mistake. The FDA should not be completely physician-run. You've got to get somebody on there who actually knows something about the the whole questions about how you do risk rate return analysis, cost benefit analysis, any one of these other things. So a good healthcare economist would make an enormous difference in the way in which it operates. But we have this peculiar field specialization, which essentially will lead to long-term disaster. So is there going to be help? Yeah. Personalized medicine will make a difference, but it's very expensive in the way in which it works, and it's going to be subject to all sorts of regulatory and liability risks. So I think what you have to say is that the second derivative is negative. The rate of the increase is going to slow down over time, unless and until you start to change things. And looking at the politics, both in this administration and to some extent in the last one and the one before that, I do not see many people who you would have small government pro-growth models on their mind when it comes to figuring out how they discharge their regulatory functions. And the point of this little talk on global pharmaceutical pricing is to tell you it's really a very hard question to do. And before you denounce, it's better to understand. Since I think I understand a little, I'm quite happy to denounce a lot.